Hello, I'm Dr. Lisa Belisle, and this is Radio Maine. Today I have in the studio with me Dr. Jen Palminteri, who is a fellow physician and also a fellow art lover, I would say.
New art lover. I feel like I'm just sort of coming into it after making some new friends that know a lot about art, which has made it much easier.
Well, to be honest with you, that is how I became an art lover myself, is through friends. So welcome to the crowd, I guess.
Thank you for having me.
So that's a good thing. You're also a fellow Maine woman.
Yes, I was born in Alfred, so I lived there and left for training and then came back. And I've been in Maine sort of for my adult life, so it's been nice. I feel like I'm like firmly in the community, and I see patients that I know and families that I know and their kids sometimes, and so it's nice.
So that's interesting. If you're from Alfred, and where do you practice?
In Portland.
In Portland. But you still draw people from the southern part of the state?
Yeah, I do pulmonary disease and critical care medicine, so for kind of complex disease, they tend to travel a little northward for that. And I don't know, they sort of know my parents, and they're like, Jenny's a pulmonologist, we'll go see her. So it's been nice to see my parents' friends and all that.
Do you ever find it to be a mixed blessing?
Sometimes. I guess if there's sad news, it's a little hard.
Oh, yeah.
But that happens rarely, so most of the time it's pretty good.
Yeah. Well, I only ask this because, of course, you know my father.
I do. Yes, I did rotations with him in his practice on India Street.
Yes.
It's a long time ago at this point. But
I was going to say a little while ago.
A little bit, yeah.
Time. Okay.
I might have even, I was a medical student at that point, so.
Okay.
That was like in early 2000s.
Okay. So. And where did you go to medical school?
Vermont.
Right. So same.
Yeah.
Yes, I also did rotations on India Street. Also did my residency there.
I felt the same path.
Yeah, exactly. And the reason I ask about the mixed blessing thing is I find that, everybody in at least one part of the state knows my dad as a family doctor of almost 50 years. He is a fixture. And then on top of that, I have two sisters who are in medicine, a brother-in-law. That's like, you got to be well-behaved. You can't not be well-behaved if you practice in the state where you grew up and your parents still live.
Especially if your last name is Palminteri.
Yeah.
Yeah, you need to you stick out around here. Yeah, there's not many of us.
If it was like Brown or Taylor or something like that, you'd be better off. Yeah.
Fade away.
Okay. Yes, Palminteri.
Yeah.
So how did your parents come to live in the Alfred region?
They're both from sort of the New York City region, and they started at St. Francis College, which is now UNE. My dad was a year older than my mom, and they met there.
Oh, yeah. Fascinating.
Yeah, came to Maine. And my dad, I don't know, he's not much of a city boy, to be honest, so he sort of likes space and acreage between him and his neighbors and that kind of stuff. So, we've been here ever since. So
what do your parents do?
My mom was a nurse. Actually, she was a critical care nurse. And my dad worked in television for a long time, and then we owned a Pat's Pizza for a while, and now they're kind of retired, watching grandchildren.
Oh, well, that's not a bad pastime.
They're good at it.
Yeah. How did you end up going into medicine? I mean, aside from the fact that your mother was a nurse.
Yeah. I have an uncle who's an OBGYN, so there was like one other physician in the family, but it was actually this strange thing. I remember like being in physics class as a senior, and people were like going around the table and like talking about what they were going to be. And I remember the words, I think I might be a doctor, come out of my mouth, but I quite literally don't remember thinking about it before then, which feels really strange. Like, why did I just decide on it? And then, as you know, you sort of move through, and before you know it, you're a resident. You're like, how did I get here? But I don't know. I love science, and it felt kind of natural, and I don't know, I got into it sort of. I wasn't pre-med when I went into college. I was a history major, and then I kind of added it on second year. So it was great. I don't know. I feel I'm thankful that it sort of happened to me, I guess, because I think it is the right job for me. Why? I don't know. I sort of feel like my persona is that of a person who like wants to be a doctor. I'm like one of those people who likes to kind of give out medical advice and stuff, which you probably shouldn't do, to be honest. But I don't know. I like the mystery of like why somebody's sick and trying to figure out how to make them better and not hurt them at the same time. And Yeah, I don't know. And I'm very grateful that I found pulmonary critical care because I think that like fits my personality really well. Pulmonology is, I don't know. Lung disease is very interesting, and it's like it interacts with like a lot of different specialties like cardiology and infectious disease and rheumatology. And so I don't know, I get to like talk to all different specialists all the time. And patients who are short of breath are like, it's very unpleasant to be short of breath. And so when you can help them, it like really makes a big difference. It's like it's a disease that they definitely feel, right? Because there are a lot of diseases in medicine that you don't, if you have high blood pressure and your doctor tells you, and then you have to go on a blood pressure medicine, you're like, I didn't even know I had high blood pressure. It wasn't bothering me at all. And now I'm on a new medicine and I'm not happy about it. But like usually when I add medicines, I make them feel better. So that's nice.
Well, especially the critical care piece.
Yeah.
I mean, people really feel bad by the time they see you as a critical care specialist.
Yeah. That's very sad. Especially like during COVID was awful. I mean, early on, we didn't have that many COVID cases here, but it was a time when like we were dealing with a new disease. We didn't know exactly what was going on. And, there's in critical care there, you're always trying to balance the thing that you're doing to the patient, with the intention to help them versus hurt them, right? So even just a ventilator, the process of breathing that you and I are doing right now, where we pull air in and push air out as we breathe on our own, is very different from a ventilator pushing air into you. And if you don't need a breathing machine, you shouldn't be on one, obviously. But like, early on in COVID, we were intubating people when they were on a couple of liters of oxygen. And I don't know, we were probably hurting people early on because they probably didn't need them. But we're pretty good at it now. We know how to take care of people with COVID, which is nice. And the cases in the ICU are pretty low. Even the people that are listed as being in the ICU aren't sick usually with COVID as much as they're sick with some other disease and they happen to have COVID. So sometimes those statistics can be misleading, I think, a little.
Yeah, I know in our hospital system, we have a fair number of people who come in with something else. We test them. They have COVID, but that is not why they came into the hospital in the first place.
Right. You broke your hip.
Exactly.
And you happen to have COVID also.
Right.
Yeah.
Right. Which is nice because actually a fair number of people have also been vaccinated. Sadly, they still have COVID, but the symptoms are not nearly as bad, if any at all, really.
Right. I mean, at this point, it's pretty hard to find somebody who's never had COVID. I feel like everybody's had it.
I know that's true.
Yeah.
Yeah.
But for those people who had some protection on board, they pretty much do pretty well. So, thankfully.
And I know that there is a different way, not to get too technical, but I'm kind of fascinated, so I'm
Yeah.
just going to ask you for selfish reasons. But I know that we actually have done different things for patients who have COVID with regard to their lungs. We aren't prescribing exactly the same things that we would for other lung diseases. We aren't doing steroids as quickly, for example.
Right. If you come into the hospital with COVID, we've got drugs like remdesivir, which sort of act as antivirals, like Tamiflu for the flu. And then we tend to give steroids to those people early on if we're worried about significant lung disease. And then for people who unfortunately don't make antibodies or have never been vaccinated, we can potentially give them antibodies if it's appropriate. And then there's drugs like Paxlovid, which is kind of amazing, old, AIDS drugs being renewed. That's really been like a good agent for people to get and sort of minimize symptoms. So, the way that we have sort of figured out what drugs work and what drugs don't work so quickly has been amazing because it was needed. I mean, we were at risk of hurting people with drugs that weren't helpful. So, thank God they did the research quickly.
Yeah. And are they still doing the thing where they rotate the patients?
Yeah.
I mean, that's also fascinating, right?
It is. It's crazy. That is, so they've done studies for years looking at taking patients who have a disease called ARDS, which is basically like a dense kind of pneumonia picture in your chest. And the pneumonia is always in the back. And if you can rotate the patient and put them on their belly, you can help to improve their oxygen levels, and it actually improves survival. And so we used to do this with patients that were on ventilators, and we'd flip them over and put them on their bellies. But it got to the point in the hospital where even people who were just sick with COVID, but not on a breathing machine, we had them sleep on their bellies intentionally. And we would see people get better. It was pretty amazing. And that is probably just the physiology of kind of the way that we breathe and where gravity sends the blood in the lungs and things like that. So
what you're describing is interesting, though, because I think this idea that we kind of had to go back to some very basic physiology, some basic microbiology to understand something floating around that was new to us, and think about things in a really different way. I mean, I think that was a little, at least I'm on the outpatient side as a physician, but I found it kind of difficult, strange. It felt very risky. I felt like I was doing my own version of medical doom scrolling, hey, who knows stuff? I need to figure this out.
I think that was the thing that was so unsettling in the very beginning of COVID, because there would be groups of physicians or, different areas of the country where there was a lot of COVID. And so there's something to be said for experience, right? And if those physicians were doing things and having good outcomes before we had real data, we started to sort of take their considerations, like intubating people early or, medications like hydroxychloroquine were initially started for people, and don't give anybody steroids. That was early on the recommendation. So it was crazy how things were changing so quickly depending on what people's individual experiences were.
How much telemedicine do you do?
I do a little bit. I have some patients for whom they have such significant lung disease that leaving the house to come to the visit puts them down for 2 days. And so I tend to do telehealth visits for those people. And because I can make a lot of good decisions based on kind of what the patient looks like on camera, even without listening to their lungs. I can, and their symptoms and everything. So I can do that for some people. I think for other diseases, it's harder. But it really saves those patients from feeling miserable for a couple, because it's so much work. They either, they're pretty sedentary or they get terribly short of breath. And so the process of walking from the parking lot even to the office is a lot. So especially in the wintertime in Maine, of which there is a lot of winter. So I think I'm still doing telehealth for those people.
I mean, personally, I found that there were situations that I thought would be great for telehealth that turned out maybe not to be so great, but other situations I hadn't even really thought about. And then I was like, wow, this is great. I hope we never go back, because it is so good for the patients and their families.
It is. Yep. And you can get the whole family on the Zoom call. Yeah, it worked. For some people, it worked out really well.
Yeah. I mean, it caused me to think a lot about access. We talk about social determinants of health, of course, just you don't have enough food to eat, you don't have transportation. But we're talking about, I think you and I probably have some overlap of patients that they need to get in a wheelchair, which means they need a wheelchair van, or they have to have their own wheelchair van. And then you've got ice on the sidewalk, and sometimes the sidewalks don't have cuts. And I think that I always knew that was out there, but I think when COVID came along, it really caused me to think why? Why do we make people, not all of whom really need to come into the office, come in and see us when we can do so much of it remotely? We
can. And even just talking to people about their disease, maybe you spend less of the visit on the exam and more about the talking and the history and what they're feeling, and their families can chime in, and you can even potentially see kind of where they live. And I think that's helpful. I think that has been pretty helpful. I was definitely doing more telehealth during the middle of the pandemic there. My patients were very nervous about coming to the office, and we were also nervous. I think it was hard if somebody had an upper respiratory infection. Back when you couldn't even get a test, we were like, well, you can't come into the office. We're going to have to do this over the phone. And people are on immunosuppressants and they have cancer, and you just don't want them getting exposed.
Yeah, and you raise a great point about really seeing where people live. When there's a camera, and sometimes it's just somebody holding up their cell phone, or they're holding up the iPad for their grandmother or whatever.
Yeah.
And you see that when you talk about social determinants of health, these are real issues. These are huge problems. People I was seeing people kind of shoved into their, mobile home with like 2 bedrooms, but 12 people living there kind of thing. And, you could see like black mold and like just horrible things that I think are so theoretical, and they can tell you this is what's going on. But when you actually see that, or in my case, sadly enough, when you actually see a patient who is smoking on the camera with me, I was like, oh, well, I don't need to ask whether he's quit because he hasn't, but I'll say, can I help you with any resources, something like that. But I think for me, it really hit me like it's not that it was fake before, but it more like this is real stuff that real people are really dealing with. And somehow we need to figure this out a little bit better.
Right. And I think that the, sort of improving your health sometimes comes along with improving your life, which is not possible for everybody. There's like a lot of poverty in Maine, and some people don't even have Wi-Fi, and they have to do phone calls instead. And, trying to help them manage, nicotine addiction when there are all these other stressors, you sometimes have to modify your advice to match what the patient is even like kind of capable of doing.
Yeah, that's such an interesting thing, because I think you're right. It's nicotine addiction. It's not like you are a smoker wagging my finger at you. It is an addiction, and it is related to stress. And it's, what are you going to have to navigate without the help of this product, this way that you're medicating your life when we take it away from you. So I think being able to see it in a much more compassionate way while simultaneously recognizing like, okay, this is lung disease and we really can't have you smoking. It's like having to figure out how to communicate that with the patients.
Yeah, and to make it sort of shame-free, I think, because for people who have been smoking for 50 years, they are terribly addicted. The people that can't get down to less than a pack a day without having like terrible withdrawal symptoms, trying to quit smoking under those circumstances, cold turkey, certainly, which is very hard. Their brains are like so addicted. They feel physically terrible when they try and quit, and their brain is also starved of dopamine and all sorts of other reward chemicals, and they feel terrible about themselves. It's awful. So if you can, try and help them with like nicotine replacement and working on cutting back and just kind of, work on doing your best. And I feel like that's sometimes the best way to help people, because they feel bad enough about it already.
Right.
And don't need to make them feel worse.
Yeah. We used to think, it's all about education. If they know that smoking is bad for them, they will stop. I don't know whoever thought that was the answer, because when you keep hitting people over the head with the same message in a really judgmental way, it doesn't work. It doesn't really work. They don't really soften, It's like, yeah, I got that. I'm not stupid. I know that smoking is bad.
They know. Yeah, it's been 20, 30 years of that message. And going back to the 60s when that message really started. So clearly there's another driver for why they're continuing to smoke. And that's like a chemical dependency. Just like people get chemically dependent to other things. And it's sad.
As I'm talking to you, I'm thinking about when I started in medicine a little bit longer ago than you did. But I'll just say not that long ago. Let's just say that. It's not true, but because I have a daughter who was born my last year of medical school, and she's 26, so that tells you something. So, but I do remember back in the day that I think as a profession, we did tend to be more judgmental and a little bit less compassionate. And I think that, in family medicine, we tried to be kind of the interface. But now I'm seeing more and more people who go into specialty medicine that they're not leaving it to the family medicine doctors to be the interface. They want to be there with the patients present. They want to be communicating the message themselves. And I've really appreciated that. I've really appreciated that we're all on the same team. We all speak the same kind of language of wellness. And so it's not getting kind of funneled down the road back to primary care. So thank you for that.
Oh, I can't even imagine how busy primary care doctors' offices are with all of the requirements for all of the, sort of various metrics one has to meet. To then be like, oh, I'll turf your COPD back to your primary care doctor also feels a little bad. I think I could probably help out with that. That probably would be in my purview. So I don't know. I like to sort of take ownership of those things and do them myself. I tell my patients, if you are having an asthma attack or your COPD is acting up, call here. You don't have to call your primary care doctor. You can call here. We have somebody on call all the time. We can take care of you, and then I can keep track of when you were sick so that I know whether or not I should change your medicines or do something else or get some imaging. So I don't know. I like to I don't know, maybe I'm a little bit of a control freak. I like to know what's going on.
Well, and I appreciate that. And I know that there are some primary care doctors who are like, no, I want to manage everything. Yeah. I am not that way. And in part because you're right, it's very complex. And we know so much more about so many more things than we once did that I'm like, hey, listen, I am happy to be on your team with you, Mr. or Mrs. or Ms. Patient. And also, I'm going to have this other person on the team with me as well. And so if we can all just be clear about who's doing what and just kind of be open to the communication, I think it's really helpful.
I think it is too. And the patients are very motivated for their primary doctors to know. That is pretty universal, especially as they get older. Like patients who are in their 60s and 70s and 80s are very concerned that maybe, I just want to make sure that my physician, my primary care doctor is getting my records, and will they get a copy of that CAT scan, and will they get this? I just want them to know what's going on. So I think they still view them very much as being the center of the wheel, which I think is really important because, you're prescribing the majority of the medicines, and medications interact, and so that's pretty important.
I'm glad to know you're on our team.
I am, and I have been here for a while, so I feel like I know a lot of the primary care doctors in town, so it's very easy to just contact them. And I don't know, there's something about the efficiency of one doctor just calling another doctor and fixing the problem in 5 minutes is amazing. And instead of passing notes back and forth or communicating through your nurses or your medical assistants, it's I don't know, that I think that important professional relationship and that communication is still, it's incredibly valuable. So I like to do it, and I like it when I get called. So
see, and that's also great to hear because that is the way it used to be.
Yeah.
I know we have a range of providers now that are practitioners that are not doctors, but when we used to have, we'll just call it the doctor's lounge because that is what it used to be called. Yeah. And that is how people interacted. You talk to the person who was in the hospital taking care of your patient, and you talk to the primary care doctor who was then a family doctor or a GP, And then we had all these wonderful electronic health records, and I'm going to call them wonderful because they do have their benefits.
They do.
But I think that created this weird digital barrier, and then it took away all the human. And now you've got all I have on the other side is a name I can send a task to or an electronic health message to. And I really appreciate it when I could do the same thing and be like, okay, I know Jen. Send a little text. Okay, could you give me a call? I have this patient. I just have a question. Give a call. That way I don't have to send a patient in for a consult. It's going to take 3 months, So how do we make that happen more? That's my question to you. How do we actually get that to be more the case?
I actually think that it's, it sounds terrible, but it's social events again. You know what I mean? Medical staff meetings and places where, providers get together again and get introduced face-to-face to people and those kinds of things, because there's less of that. People are very busy, and then it's kind of perceived as an add-on to work sometimes. So I think that's really important because, I don't know, I was the house staff president at Maine Medical Center when I was a resident, and my job was basically to plan parties. But it just I don't know, if you're calling for a consult, you're essentially calling and asking somebody to do work for you, right? That's just, if you break it down to the bare minimum, that's what it is. But it's somebody, asking for your help on a topic that they consider that you have some expertise in, and that's what you should do. And if you know that person already because you were at a party with them 3 weeks earlier and you met them there, then it's a lot easier to be like, oh, hey, Lisa, yeah, sure. Oh, sure, I'll come down and see her. Sounds fine. It just changes the interaction. So I don't know. I think that those things are important, and we probably should do more of them. So I'm always a fan of parties.
Parties.
But yeah, we're social. Be nicer to each other. Not. Yeah, I think that would help.
Yeah.
If we all spent a little bit more time together outside of work, maybe. It's easy when your friends are calling you. You're like, sure, Michelle, I'll come down, no problem. Friends in the ER. But if you don't know people, sometimes you're like, yeah, I'll be down. It's sort of the way that you talk to people, I think.
Yeah, that's really true. So that's how we'll fix it. More parties Always. For doctors and nurse practitioners. And everybody out there, we're going to bring you to our party. We're going to get to know each other once again.
Yeah, Maybe know what somebody looks like by face and not just by name.
Yeah.
That would be nice.
And at some point when the masks come down, we actually will know what their full face
Gosh,
looks
that
like.
has been, I'm terrible with faces to begin
Same.
with. And then you put masks on everybody for 2 years, and now I'm supposed to know what they look like again.
know.
It's been brutal. But
Yeah. No, I feel that. I took a new job and then COVID hit like within weeks, and I was like, oh, okay. So someday when the masks come off, I'll be like, wait, do I know you? Yes, you and I have been talking for the last 3 years.
it's crazy.
This is what I look like.
I know.
So,
it feels weird to not have a mask on sometimes.
I know. It's very true. Mm-hmm. So we've been talking a lot about medicine, and thank you for those of you who are listening or watching to us go on and on about one of our passions, which is medicine. I appreciate that people who are listening or watching are interested in this, because I know I am, selfishly. But the other thing that I'm interested in is your intersection with art. And, you mentioned that it was really through knowing people who knew art, and you're relatively new to the art game. So art was not woven through your kind of educational life as you were going through.
No, I didn't. I didn't take a lot, or I didn't take any, what I remember as being like any sort of like artistic or art history courses in college or anything like that. I remember being in a music class once, but it was like as a requirement, I think. And I've always kind of struggled with, like, I was buying, prints at Target, and I was, and there was nothing that I was anxious about finding art that I both liked and was going to like fit a style that I wanted to match my home. And this, for whatever reason, like caused me anxiety, to the point where when I like redid my condo, I wallpapered the entire like main space, thinking that it would decrease the amount of art that I had to buy. This was on the list of the reasons why I was getting wallpaper. I do love wallpaper, but I was like, oh, well, if I get more wallpaper, I won't have to buy as much art. And then COVID happened, and you're in your home a lot, and there is not much on the walls except for your wallpaper, and it felt unfinished all the time. And I met Emma, and I went to one of her gallery openings, and while I was there, I saw a piece by Dietland, and I loved it, and I told Emma that I wanted to get it, and then I heard Dietland talking about kind of the techniques that she uses and the things she's trying to represent in her pictures. And one of them was that the lines kind of represent breath. And I was like, oh my God, this is perfect. I'm a lung doctor. This piece is about breath. I liked it. It's perfect. And so I got it and put it in my home, and I love it. And since then, she's been helping me like find other pieces, but it feels nice. Like my home feels much more finished now. Like it felt sort of stark before, and now it's like homey. I don't know. So it's definitely been, kind of a new hobby, I guess, for me, which as adults, having hobbies is hard. But I don't know. I like talking about art with Emma, and having her show me pieces that she likes, because she knows what my home looks like and what she thinks would work well in there. So I don't know. It's been lovely, and she's a lovely new friend. So.
Well, Emma Wilson is absolutely a lovely person, and I've known her for a little while. And she is. That's the excellent thing about Emma, is that she gets to know you as a person. It's not just like, oh, this blue thing would look nice next to your pink thing.
Yes, exactly.
It's not just about the visual. It's like, I think this would really feel good to you. Yeah. This would really fit what you want to have happen in your house.
Yeah, and she's kind of nailed it. Like everything she brings over, I like. So it's become a new, wonderful, and also expensive habit. So
it is an expensive habit.
Yeah, it's a good thing to spend your money on, though, I guess. So.
Well, I think so. And we brought a Dietland in today behind us, and I have a Dietland at my house, and I love Dietland, who's also just wonderful. So that's the thing.
Yeah, she is.
She's to know the person.
Such a lovely human.
Yes. And I think that for me, I don't know if this is true of all people in medicine or like highly educated people who just spend lots and lots of years in school, is when there's something that you don't know, you're like, oh, but I've been to school a million years. Shouldn't I know this? Like, which is stupid, because why would I know art? I didn't study art. I studied all this other stuff, but not art. But it can be really intimidating, as you say, to be like, okay, I don't know this. Who do I talk to now?
It seems hard to be able to truly appreciate something if you don't have like enough, like either knowledge about it, or I was like, do I like that? Am I supposed to just like the way it looks? Is that how this works? It's such a strange thing when you're like sort of uneasy about like whether or not a piece of art like goes in your home, and then you see something and it's perfect, and you're like, oh, that's it. And it was like an effortless decision. So.
Yeah, and it can be, I think art in particular can be a little intimidating because there's this idea like, oh, it's an investment. I'm investing in the future. It's like, well, okay, like, what are you, the Met? I mean, you're not going to be selling your stuff to another museum someday. Exactly. It's probably going to maybe go to a grandkid. I don't really know. Or whoever, the neighbor at a yard sale if you die penniless and alone, whatever.
Yeah, exactly.
But I mean, if you look at this and you think, well, I really don't know what the extrinsic value of this is, but I value it. It's my value. It's like going to a restaurant and being like, well, I don't really care if this is a Michelin-starred restaurant, but I like this food.
I like the food.
Yeah. So I wonder why it is that we've gotten so far away from trusting our own selves and our own feelings about things like art, for example.
I think there's sort of lots of jokes made about people standing in front of like a pure white canvas and being like, what do you see? And it's like, I don't see anything. What do you mean? What do I see? And I feel like, we sort of like make fun of people who wax on about something that's like not even present or whatever. But like once you sort of just let all that go and then see something and like it and commit to it and just do it, it's really lovely. And then like when she brought it to my house, I was like, oh, it's perfect. This fits perfectly. So it's actually moved around my house a little bit at this point.
Oh, so Dietland's work is wandering your walls? Is that what
a
I'm
little
hearing?
bit, yeah. I'm trying to find like the sort of perfect spot to put it, and I think I figured it out. I think it's over the couch. Okay. I think it needs a matching piece, though, which I talked to Dietland about. I think it's like a space that needs two pieces.
I mean, it's like getting a dog. You can't just have one. You have to have at least two.
Dog needs a friend. Yeah, I don't have it. Yeah. No dogs for me, but yes,
you have art.
Exactly, I have art.
That's all you need,
plants,
really.
Exactly.
Right. Yeah. No, and I think that's true too. And to be clear, when we have art that comes into our home, often it wanders the walls. And it's actually like a little pet. We call it fostering. We bring our art in, we foster it, we think about adopting it, we move it to place.
And like, oh, this is its home. This is where it belongs.
Yes. I mean, it becomes like a living thing that you actually interact with in an interesting way. So, and that for me, I always enjoy that because that's sort of the non-doctor side of my mind. Like, because the doctor side of your mind, people, if they heard me talking about fostering art and letting it wander the walls, they'd be like, I think you need to get back to the science, lady. But the non-doctor side, which actually I think is kind of the doctor side, I think that we all as doctors or people in the medical profession actually are very creative in spirit. Our brains have been trained in such linear ways that it's sometimes hard to kind of pull back and be like, no, actually, we're problem solvers and we're creatives.
And, the human body falls apart in many ways, and sometimes you have to figure out the right way to take care of them. And you have a lot of knowledge and guidelines and things, but sometimes it does take a little bit of creativity on how you're going to make that person better.
Yeah, and sometimes it takes a knowledge of people. And as long as I've been in medicine, I still don't know everything about people.
Yeah. People are quirky.
I mean, I think that's actually the most fascinating thing I have found in my entire medical career is that I think I know something or someone, and then somebody else shows up and I'm like, oh, you're a different version of that. Yeah. That's so fascinating.
I know. One disease will cause somebody terrible symptoms, and you can see the exact same disease in a different person and they are still thriving. It's crazy, like coping skills and just, adapting to disease and, because, we're all falling apart from like age 25 to 86 and a half or whatever the life expectancy is of a human. But so it's just figuring out like what you can handle and what you can't and fix the things you can.
That's right. I mean, there is an inevitability about
there
certain
is.
things. Right?
Yeah, there is.
And so it's more about like, okay, we're all like a bunch of rickety trains on the tracks, right? Just let's keep the wobble to a minimum until we get to the end and try to sort of enjoy the view along the way.
That's right. Absolutely.
Yeah. Well, I very much enjoyed our conversation today.
Me too.
Going back and forth from art to medicine and all the hither and yon. I didn't even get a chance to ask you about Italy, so I guess the next time you and I talk on air, we'll talk about Italy.
Which was lovely.
Yes. It's because that's the other thing, travel. Oh my goodness, a whole other topic. But
Yeah.
so I
What a
guess the
fun
next time we have like a medical or art related gathering, then everybody's going to come and ask you about Italy.
Yeah.
That is going to be what you do. Come talk to Dr. Jennifer.
I went on about
Palminteri.
it for weeks. So
Yeah. Okay. So that you need to ask her about her Italian trip. So I appreciate your spending your time here with me today. It's
Thanks
really
for
been a
having me.
lot of fun. And I usually say I encourage people to learn more about the art and the artists. But in your case, probably people don't want to learn that much about you because once the time they get to see you, maybe they're a little
don't
sick.
want to see me.
But
Yeah.
let's just say that you're proud that, let's assuming that you're very good at your job, that if somebody needs to see you, then you are the right person to see.
I'm happy to see them.
Yes, that sounds good. I'm Dr. Lisa Belisle, and I have been speaking with Dr. Jennifer Palminteri today. She is a pulmonary and critical care specialist, and like me, a novice fellow art lover. So I encourage you to maybe go to one of our Portland Art Gallery openings, and of course she will be there because she likes a party, from what I understand, and get to know Jen. And hopefully you won't need her services, but if you do, I think she's probably very good at what she does. This is Dr. Lisa Belisle. Thank you for watching and listening to Radio Maine. Thank you, Jen.